Good morning, ladies and gentlemen and fellow colleagues. Thanks to the AMMF and Helen for inviting me to talk about the BSG Guidelines for the diagnosis and management of gallbladder cancer. So, unfortunately, gallbladder cancer is an aggressive disease of the biliary tract. It's associated with poor prognosis as the majority of patients present at an advanced stage. There is significant geographical variation with high incidence rates reported in countries like Chile and in many regions in Asia. With the increase in incidence that has been reported recently, there is going to be an increase in cost in global burden in the management of gallbladder cancer. So let's look at the data in England. Across all cancer alliances, we have now seen an increase in incidence. We also showed that there was a higher incidence in women patients and also in areas with increased deprivation. Looking at the cancer alliances map, with the darker purple being areas of higher incidence, what we can see between the two study periods, there's clear increase in incidence for gallbladder cancer in all regions. With respect to deprivation, 5 being the most deprived, as we can see in this graph, patients with the most deprivation had the highest incidence of gallbladder cancer. The data also showed that the majority of patients presented through the emergency pathway. Majority of patients were also diagnosed with stage 4 advanced disease. This may have been a contributing factor to the poor survival outcomes that were seen across the regions. This graph just shows that the emergency pathway is the highest route of presentation. And looking at the Cancer Alliance map, with regards to survival, the darker the purple, the poorer the survival, as we can see here that the survival is generally poor across the regions. So looking at the management of gallbladder cancer, what was very clear in the data in England is that there is survival differences across all cancer alliances. We also found that there was a variation in treatment provided between the cancer alliances. Taking this into account, there is an urgent need to have a standardized UK guidelines for the management of gallbladder cancer. The liver section of the BSG has commissioned us to write the diagnosis and management guidelines for this devastating disease. And we have written these guidelines and we are due to submit it shortly. There's more than 50 recommendations from all specialties. But today, due to time constraints, I'm just going to go through key recommendations in certain specialties. So we start with pathology. So the histological assessment of all gallbladder resections should follow the Royal College of Surgeons or Pathologists pro forma. We should report it according to the TNM staging. With regards to the tumor, there is T1, T2, T3, and T4, and that will depend on the level and degree of invasion. With respect to lymph node disease, N1 represents lymph nodes in the portal area, and N2 are more distal lymph nodes. Patients with distant metastasis will be classified as M1. With regards to other recommendations, all histology of gallbladder cancer should be reviewed in the HPB regional centers. This would also include incidental finding of gallbladder cancer following cholecystectomies, including in the DGHs. In patients who are not fit or unsuitable for surgery, but are candidates for systemic therapy, tissue acquisition is recommended. In terms of radiology, all patients with suspected gallbladder cancer or presenting with incidental gallbladder cancer should undergo a staging CT chest, abdomen, and pelvis. PET scan can also be considered in patients as part of the staging to determine nodal disease and identify distant metastatic sites such as the liver or the lung. This is an example of a CT scan. This is the gallbladder. The tumor is here. It's currently invading the common bile duct, giving biliary duct dilatation. This is a patient with advanced gallbladder cancer. Other recommendations from the radiology section include that patients should undergo an MRI scan of the liver to determine the degree of invasion in the liver or identify small liver metastasis. In terms of obtaining tissue, a lot of patients will have liver mets, and we can consider ultrasound or CT-guided biopsy. In terms of endoscopic recommendations, there's quite a few recommendations on obtaining diagnosis and further management. I'm just going to go through 3 here, which is in terms of diagnosis, we can consider EUS-guided biopsy in terms of liver mets or the gallbladder tumor in certain cases where CT or ultrasound-guided biopsy was not successful. All biliary obstruction should be treated with stenting, and it will depend on the type of stent we use, depending on whether the patient is an operable candidate or is going for non-operable treatments such as palliation or systemic therapy. With regards to surgery, our recommendations will cover 2 sections, which is the first one, patients who have suspected gallbladder cancer on imaging, and patients who have incidental finding of gallbladder cancer following a cholecystectomy. All cases which are going to undergo surgery and determine resectability should be discussed in our regional HPB MDT. The current recommendation is a radical cholecystectomy, which includes resection of segment 4B and 5 of the liver and also portal lymphadenectomy. In terms of lymphadenectomy, the current recommendation is we should at least try to retrieve 6 nodes or more. For tumors which are involving the bile duct, in certain cases, we can consider bile duct excision and reconstruction. In terms of other organ resection or performing a major liver resection for more advanced cases, this has been shown to be beneficial in a small number of patients. But prior to doing this, there needs to be MDT consensus that we have selected the correct patients to undergo such major radical operations. In terms of incidental gallbladder cancer, as stated before, the histology needs to be reviewed in our regional HPB MDTs, and patients should be staged with a CT and MRI scan. Following this, if they are operable, centers can consider performing further PET scans or proceeding to a diagnostic laparoscopy. In terms of surgery for this group of patients, once again, we would consider the same liver resection approach, which is a segment 4B5 resection and also portal lymphadenectomy. A cystic duct assessment is also performed, and if there's tumors at the margin, we would consider bile duct excision and resection and reconstruction. At present, we would not recommend port site excisions as the presence of disease in these port sites would be considered metastatic. This figure just shows the path for surgery for gallbladder cancer, which is we start with a liver resection of segment 4B5 with the gallbladder cancer tumor, portal lymphadenectomy, and for certain cases, we would consider bile duct excision. In terms of oncology section, this is the one section where there were loads of or quite a few randomized controlled trials, unlike the other sections where our recommendations is based on national databases, retrospective studies. So with oncology, we have good level of evidence. So the current evidence is to recommend adjuvant systemic therapy, single agent capecitabine, and this is primarily due to the BILCAP study, which showed that patients who underwent adjuvant therapy with capecitabine following surgery for biliary tract cancers had a significantly better overall survival compared to patients who did not. In terms of patients with unresectable gallbladder cancer, we have had a talk before by Prof. Bridgewater, who showed all the various types of trials that have been happening for biliary tract cancer, but first-line chemotherapy with cisplatin and gemcitabine is currently recommended, and obviously targeted therapy should be included in selected cases. With regards to radiotherapy, there are a few trials for radiotherapy, and adjuvant chemoradiation can be considered for more advanced gallbladder cancer and patients with N1 or R1 resection. Palliative radiotherapy can also be considered for certain cases with advanced disease. A recent published trial has shown that the addition of radiotherapy with standard adjuvant capecitabine and cisplatin has shown to have a better overall survival than just chemotherapy alone. In terms of patient and public perspective recommendations, all patients diagnosed with gallbladder cancer should have access to a specialist nurse as the key worker, dietitian, and charities such as the AMMF. And also all patients are also entitled for a second opinion. I would just like to take this opportunity to thank the guideline development group. A lot of you are in the room today, so thank you for all your hard work. Thank you.